Hello, good afternoon, everyone. Welcome to the McMaster Health Forum here at the McMaster University in Hamilton, Ontario. This is our latest in our series of webinars from our Queen Elizabeth Scholars. Our agenda for today's webinar is to give you a quick summary of what the McMaster Health Forum is, what the Queen Elizabeth Scholarship Program is, and then I will turn it over to our Queen Elizabeth Scholar presenter for today, who's Jean, and she will be joining us remotely, and she will tell you where she is when we get to her. The McMaster Health Forum is a leading hub for improving health outcomes through collective problem solving. We harness information, convene stakeholders, and prepare action-oriented leaders and act as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The version of the Queen Elizabeth Scholarship Program that we offer here at the McMaster Health Forum is Strengthening Health Systems. Our scholars will contribute to strengthening health systems and become part of our large and growing network of health system leaders. We have currently had 2 different cohorts of scholars. Our first cohort is listed here. We had 13 scholars who went away primarily in the calendar year of 2016. And currently our second cohort, which comprised of 22 people, are currently doing their webinars throughout this fall term, and our third cohort will be getting ready to go away in 2018. Our presenter for this webinar is Jean, who was at the time of her internship a BHSC undergraduate student here at McMaster University. Her research experience had fostered an interest in chronic disease management and health system strengthening, and her goal for her internship was to strengthen her understanding of health systems research and how it can be utilized to address pressing health issues. Jean is no longer here at McMaster. She's at the University of Ottawa in the MD program. So Jean, without further ado, I'm going to turn it over to you for the rest of the presentation.
Thank you so much, James, for the introduction, and I'm really happy to be here to present today about my project in Melbourne, Australia. So I worked with the Australian Prevention Partnership Centre, and it's an interesting model for a research organization, as it's a national collaboration of researchers and policymakers and practitioners across the country. So there are researchers based in Melbourne, in Sydney, and in various different institutions that collaborate with each other. And this organization is hosted by the Sachs Institute. So specifically, I worked on the Prevention Tracker project, learning from local data to activate systems for chronic disease prevention. And we were based in Deakin University in Melbourne at the Burwood campus. And specifically, my project was focused on exploring barriers to community partnerships for funding. So for this presentation, I'll go over a little bit about chronic disease prevention and the background of it in Australia. I'll talk a little bit about Prevention Tracker as a whole, the project, as well as the study methodology of the literature review that I did, and then the results and discussion from that project, as well as key personal reflections and lessons from my QES experience. So chronic disease in Australia is a major problem. It's responsible for 83% of all premature deaths in Australia, and it accounts for over 60% of the disease burden. So when I mention chronic disease, we're talking about heart disease, stroke, heart failure, chronic kidney disease, lung disease, type 2 diabetes, all these conditions that progress over a long period of time and can be impacted by various environmental and lifestyle factors. And now this issue is also going on in Canada as well. But the difference here is Australia spends around $2 billion on prevention each year, or $89 per person. Now it sounds like a lot in total, but this is actually considerably less than the other OECD countries, much less than Canada and what the US spends, and overall it's actually only 1.34% of total healthcare spending, which is interesting because a lot of studies now, they talk about how if we invest in prevention now, we save a lot of money in treatment and healthcare spending later down the road. Whether or not this is actually, says that we should be spending more on prevention is actually a complex question, which brings me to my next point, that prevention is complex. So currently there's a focus on individual behavior change in the space. Programs that tell people to exercise more, to run, to eat healthy, physical activity programs at the gym. However, we're currently living in an obesogenic environment in which calorie-dense foods are readily available. 200 years ago, you couldn't just go into the grocery store and get a bunch of, or go to the fast food market and have all these unhealthy foods at our fingertips. Also, we're finding that physical activity guidelines are really difficult to follow with the sedentary lifestyle that society promotes. So the environment has really changed and influenced the way that we make health choices. And also social determinants of health play a huge role as well. So your education level, poverty, your working conditions, they heavily influence the lifestyle choices of an individual. For example, if you're living in the center of a very urban area, you may be living in a food desert in which you don't have access to healthy foods and grocery stores and fresh foods. So when we're running these programs telling people to exercise more, or physical activity programs, or healthy eating programs, they're very, very important, but they also don't address the root causes of the whole system of that contributes to obesity and these chronic diseases. And so there's a need to examine prevention using a systems approach. So what do I mean when I say a systems approach? So a system is, the textbook definition is that it's a regularly interacting or interdependent group of items forming a unified whole. And so the way I think about it is that a system is generally synergistic. So that means the sum of its parts, the whole is greater than the sum of its parts. So 1 plus 1 equals 3. Or for example, if someone asked you, what's a cake? If you just talked about it, if you just described it as, it's 2 eggs plus 3 cups of flour plus 2 cups of sugar, you're not really doing justice to the whole or to the concept of a cake. In the same way, systems thinking examines these systems as a whole, not just the parts, but how these parts interact together, the relationships between them, their boundaries, the different perspectives within a system, how they interact to create the system that we see today. So one thing that we can use to analyze systems are causal loop diagrams. So for example, depicted here is the system of tobacco consumption. So you can see here that there are elements of various players in the system, the tobacco industry, tobacco research, the government, and the arrows depict the relationships between all these different factors, whether they're positive, they contribute to each other, or they're negative. If one increases, another decreases. And so you can see here that it's quite complex, that it's not just, there's individual behavior, people deciding to be a smoker or deciding to quit, but then there's also all these factors around it that contribute to that. Also, when we think about systems, a framework that we often look at is the WHO Health Systems Framework. So this describes all the components of the system building blocks. So for service delivery, this is talking about health interventions, delivering them to those who need them, where needed, in an efficient, safe, and effective way. The health workforce are those people that are involved with delivering services, and it's important to consider the relative numbers. Are there enough staff? Are they distributed in an effective way? So are there enough staff in rural versus urban areas? Are they competent, responsive, and productive? Health information systems are very important. They ensure that we look at the production, analysis, and dissemination of health information on how the health system is improving or not improving, as well as medical products, vaccines, and technologies. You see here that while a lot of the other components of the health system might be functioning, if we don't have the drugs or the technologies to treat people, then it'll definitely raise some issues. Health financing refers to how we pay for services, whether it's public, private, how people access these services, and whether financial catastrophes would impact that. And then finally, leadership and governance. What are the policy frameworks that exist to oversee the healthcare system? And all of these components work together and influence each other in order to improve health, make sure that we're responsive to healthcare needs, contribute to social, financial risk protection, as well as do this in an efficient way. So in terms of my project in Australia, I was working with the Prevention Tracker team, and this project focuses on local prevention systems in communities. So we worked on a community level, and basically we mapped out or asked the question of what do local prevention systems look like? So looking at what are the policies and programs that are currently in the prevention system, as well as the other elements that influence the chronic disease prevention system at a local level. And then once we have that information, understanding or looking at, what is the potential that's already there, what capacity is already there, and what can be done to harness that capacity and build on the system. So there are various components of Prevention Tracker. They do a systems inventory of health and well-being programs, so looking at all the programs, policies, and regulations that affect chronic disease of the citizens of the community. They also map out indicators of livability, so things like how many grocery stores are in this vicinity, how many green spaces, places that sell alcohol, as well as they do a community snapshot, which looks at the health status of the citizens. So what's the rate of obesity or alcohol abuse, issues like that. There's also an organizational network analysis that is conducted. This basically quantifies and looks at the number of organizations that are connected to each other across the community and how densely connected or how often these organizations work together. And then there are key informant interviews where basically we have researchers that go into the field and interview stakeholders that are involved in prevention in the community and ask them, what's going on right now, what are things that could be improved, and what's being done well right now. So Prevention Tracker is currently occurring in 4 communities across Australia. You can see that they're spatially quite far from each other, and the first community that signed up is Glenorchy. It's actually just off of Tasmania. It has a population of 10,000 people, so it's quite a small town, and it's a little bit colder than the rest of Australia, being that it's located a little bit more south. There's Albany, which is in Western Australia, located on the other end of the country. It has a population of about 300,000, which is still quite small, but much larger than Glenorchy. There's also Broken Hill, which is located in the state of New South Wales. Broken Hill is located in the Australian outback, considered a rural town in the desert. And then there's Gold Coast, which is 640,000 people, which is much greater than the other 3 communities. And it's actually a metropolitan city just off of the coast of Queensland. Had the opportunity to go there, and it is beautiful. It looks like Miami. It's actually, it indeed is a golden coast. So my project focused on some of the research findings that came out of the Prevention Tracker in Albany. So on the diagram on the right, this is a graphic that was produced just synthesizing the main research findings from the project in Albany so that they could, present the results in a comprehensive way to the community in a way that's interactive and easy to follow. So you can see here some of the interesting findings, stats about the population. Also something that they found was that, 70% of the people in the community shown in the top left of the diagram, 70% of people are overweight or obese, but in fact, 4 out of 5 people rated their health as a great or excellent. So there seems to be a mismatch there. And you can take a look at this after the presentation as well if you'd like. So in terms of the investigation in Albany, we found there was a disconnect in terms of some of the findings. And so that produced a research question which I based my literature review off of. So they did an organizational network analysis, which identifies and quantifies the relationships between organizations in a community. So they sent out a survey to various governments, organizations, local organizations, community groups, and then asked them about their relationships with other organizations in the community. And then these diagrams shown here were produced to depict the relationships. So you can see here that the network of resource sharing between organizations is fairly densely connected. So the organizations, there are a lot of lines in between the organizations. Each dot represents an organization. Each line represents a connection between them. And you can see that it's quite dense. And on some diagrams that aren't shown on this slide, they also showed that organizations were really well connected in terms of awareness of each other, information sharing, and other aspects. However, in Figure 2, you can see here that the network of joint funding relationships between organizations were much less dense. You can see a lot less lines in between the organizations. So the question arises, what makes joint funding partnerships different, especially because, in order to achieve large-scale impacts, often organizations apply for funding together to launch a large initiative. So what causes this disconnect? They also did key informant interviews, which reflected a very similar thing. They showed that informal networks and relationships were important in getting things done, and organizations often noted that they often felt external pressures to partner with each other, yet they found it really difficult to do so, and they found that they didn't have the time, or that they found it was very difficult to partner for funding. So that's where my project came in. So basically, I looked in the literature to gain a deeper understanding of what are the barriers to community partnerships for funding, and what might be happening on a community level. So in terms of the literature search, I used words such as community, collaboration, partnership, funding, and a grant, and search databases of Scopus, EBSCOhost, ProQuest, and basically the initial search pulled up 489 results. 38 were selected after title and abstract screening, and then 17 were included in the final study. And in terms of articles, we wanted to focus on not just articles in chronic disease prevention, but also partnership in terms of social services and or health promotion, because they might have some findings that are applicable to our situation as well. We looked at articles talking about partnerships on a community level. so not including state or international level. We included the most recent literature since 2010 and included a variety of article types. We excluded articles that talked about partnerships in countries such as various countries in Africa without comparable health systems to Australia, and we also excluded articles that focused on research partnerships because those partnerships, the nature of those partnerships are a little bit different than the ones that we were interested in. And so what did the literature show? So in terms of key themes from the literature, they showed that there is an increasing movement towards using grants to promote inter-organizational relationships. So a lot of grants would require organizations to partner with each other in order to apply. So they'd say you're eligible for this grant if you are partnered with 2 other organizations. However, they found that this method was not necessarily, this is generating pressure to partnership, but it wasn't necessarily supporting synergistic, productive partnerships. And the barriers to these partnerships were located at 2 main levels, challenges with the funding structures, as well as challenges at the organizational and community level. So in terms of the funding structure barriers, so they found that grassroots emergent partnerships are very different from top-down organized partnerships. So what I mean by grassroots partnerships are organizations in the community, they see like a gap or a need, and they identify possibly that you know, we don't have the capacity within our organization to address this gap, but organization B over there does. And so we reach out to them, and fueled by that passion and that need, they start to collaborate with each other. Whereas these top-down organized partnerships, for example, would be ones that are mandated by grants or such, and those grants could contain like restrictive requirements for the partnerships, and they're not as organic as the ones that emerge bottom up. They also found that funding can formalize partnerships and require partnerships to meet certain demands that aren't that are difficult to meet. Also, grants often occur in short funding cycles, a couple years, whereas relationships between organizations take time to develop, just as it takes time to foster a relationship between a coworker. Just because a funding cycle ends doesn't mean that it's difficult to end a relationship as a funding cycle ends. Also, organizations that do similar things are expected to apply for the same pool of funding. So even though they're aiming towards the same goals, this causes them to view each other as competitors rather than collaborators, and this can change the dynamic between community organizations. On a community level, there often isn't enough organizational capacity to partner for funding. Partnerships take a lot of work, meetings, making sure that everyone's on the same page, and moving this up to the grant level requires a lot of meeting requirements in terms of writing grant proposals, submitting indicators and updates to the grantees and grantors, and this can cause a lot of strain for organizations. And given that a lot of community organizations are very pressed with daily tasks, partnership development might not be on the top list of their priorities as such. And also, the last point is, I guess, not all partnerships are meant to reach the stage of partnership for funding. Partnership for funding usually occurs in the later stages when organizations work together and they start realizing that we work really well together, and it's indicative of partnership maturity. So not every partnership is meant to reach that stage. So in conclusion, or I guess the results of the study, showed that partnerships face a lot of barriers in terms of applying for funding together, but more research is required to gain a deeper understanding of these barriers and identify solutions. But what's interesting is that communities in the Prevention Tracker project are also, not just Albany, other communities are also identifying similar issues. This is a diagram from the group model building session in Glenorchy, Tasmania, where they talked about issues of funding and collaboration and how difficult it was to support funding collaborations. So in terms of key lessons that I gained from the experience, I've organized them into 5 main points. So the first one is, I would say that when I was first thinking about systems thinking, it was very overwhelming. I understood the concepts of it, but making sense of a whole complex system, like in my mind, it was like this jumble of blue arrows. It was very complicated to me, and I didn't really make sense of it. And throughout this internship, I think it really helped me gain the tools to understand systems thinking in a functional way, although we'll never fully understand systems and the complexities of them. Tools such as building these causal loop diagrams or group model building sessions helped me to understand how can we think about a system in a functional way and use that to inform something. Also, I saw the importance of advocating for chronic disease prevention. Prevention is something that's difficult to invest in because it's not a flashy thing. Investing in cancer treatment, you can say, oh, we saved the lives of this many children, or you can tell the story of a child who was saved. And so it generates a lot of media attention, but prevention, no one's going to thank you for, thank you so much for preventing me from becoming obese. You don't really see stories like that. And so prevention needs to be advocated for. And also the results of investing in chronic disease prevention don't happen many years down the road, let's say 10 years. And if political cycles are 4 years, it's very difficult to generate the results that politicians or various government officials require in order to, invest in prevention. And so because prevention is so difficult to invest in, but it's so important to do so, we need to advocate for it. In the the previous Australian election, they actually cut a lot of the prevention budget and changed the whole prevention space. So that was a big lesson for me. Also, I think I gained a deeper understanding of the Australian versus Canadian healthcare systems. The Australian system uses a two-tiered system where there's private and public involvement in terms of provision of hospital-based care and care delivered by physicians, whereas Canada has mainly a public system financed by the provincial and federal governments in order to deliver hospital-based physician-provided care. And so seeing the dynamics of that and how that influences care was very interesting to see. Furthermore, I learned about the importance of common language. So when I first attended a couple meetings in Melbourne, they often talked about, oh, we need to invest in common language of prevention. And I thought that was great, like it's really important, but why did we need, I didn't really fully understand why we needed to spend so much time thinking about the words that we use to describe prevention. We could just use that same amount of time to, invest in running more programs. But as the internship went on, I realized how important common language was, and it's not just about the words, it's about common understanding. If we don't have the words or the common understanding to talk about something, it's going to be very difficult to collaborate with other people and to understand what they mean when they talk about prevention. And so to make sure everyone's on the same page, developing a common language for prevention would be very important. And finally, I learned a lot about working with communities, not just in communities. I'd always learned about community work in some classes related to community-based participatory research. However, this experience helped me really witness the impacts of it. You know, when we work with communities, just not coming in with any assumptions and realizing that each community is so different. I had the opportunity to visit Tasmania as well as Broken Hill and Gold Coast, and just seeing that each community is so different that even though Prevention Tracker is essentially the same project, the way it rolls out in each community is so different. And each area has a local advisory group of various local stakeholders that actually meet with us regularly to talk about how they see the project rolling out, and they help us inform how to carry out Prevention Tracker in the various communities. So it's very important to listen to the voice of locals, and yeah. So overall, systems thinking can be applied to chronic disease prevention in order to understand its complexities. My study showed that community organizations face various challenges when partnering for funding, and these challenges they occur at both the organization level as well as a higher level created by funding structures, and future research is required to gain a deeper understanding of these barriers. So yeah, thank you so much for listening to my presentation, and feel free to ask me any questions.
Excellent. Thank you very much, Jean. That was very informative. For those of you who are online, I'm going to ask that you please type your questions into the chat box that you see in WebEx. For those of you who are joining me here in the room at the McMaster Health Forum, just put up your hand and we'll have you ask the questions, and I'll repeat it online for those who are online and for the recording for YouTube later. I will ask the first question, Jean, while people are thinking. So I was intrigued by the fact that the Prevention Tracker looks at 4 different communities within Australia. And I'm just curious how those 4 were chosen. They all seem to be slightly different, so I'm just wondering if they are were selected because they, as a whole, represent the different facets of Australian society, or was there other reasons why they were selected?
Yeah, that's a great question. So actually, the Prevention Tracker team didn't select the communities. The communities themselves heard about the project and reached out to the Prevention Tracker team and said, you know, we want to see this in our community. And so that's kind of how it started. In terms of Prevention Tracker, it was actually rolled out as a pilot project in Glenorchy, and then they expanded it just recently this year to the 3 other communities. So that's how it happened, yeah.
And did you get a sense while you were there that there may be expansion to other parts of Australia? So I noticed that obviously the northern part of Australia was noticeably absent.
Yeah, so I think the Australian Prevention Partnership Center is currently undergoing some structural changes because it just gained some new funding. And so right now, in terms of the Prevention Tracker project, they're not quite sure about the future of the project. They're hoping that it can be expanded, but they're not sure in what form or in what shape or form. So actually they're not sure at the moment, but I'm sure we'll find out a couple months from now.
Great, thank you. So I'll ask again if anybody has any questions. If you're online, please type it into the chat box. Anybody in the room? We do have one question in the room, so go ahead and I'll repeat it for those online. So we have a question from a Kiwi scholar who also spent some time in Australia, and she wants to know if any part of your work looked at the unique needs of the Indigenous populations in Australia.
Oh, that's a great question. So unfortunately, no, this project didn't look at that. But I noticed that when I went to Broken Hill, that Indigenous issues were a very big topic of focus in the community, and so some of the organizations that were included in the organizational network analysis as well as the stakeholder interviews, they were involved in Indigenous health. So yeah, but unfortunately we didn't focus specifically on that.
Great, thank you. So we have a question online. We actually have a series of questions from the same individual, so I'll read all of the questions and I'll let you answer them as you see fit. So have you noticed any trends in the various network maps, example, resource sharing, funding collaboration, etc.? Was there a consistent key player, highly connected in the network? And if so, what do you think are the characteristics, example, they are a prominent stakeholder, that put them in that position?
Thank you, Kirsty, for your question. Yeah, so there are, so in terms of, let me go back. Yeah, they do differentiate between the central organizations as well as the peripheral organizations. So the central organizations are shown in red. Those are the ones that are more connected and more central, and then the ones in the periphery are less so. Unfortunately, because of confidentiality reasons, we try to keep all the organizations anonymous in the organizational network analysis survey. So I can't say which stakeholders were the ones in the center. But yeah, we did look at patterns of who was in the center, who wasn't.
So we have another question from someone online. So I'm curious about how you found Australia in general. What did you do for fun? Did anything about Australia surprise you? How do you think your experience compares to those of Kiwi scholars from the first cohort who also went to Australia?
Great question. I loved my experience in Australia. I had the opportunity to travel across Australia and see the various different parts. So it's so different from the south to the north. Tasmania is this state with so many national parks, wilderness, mountains. I did a lot of hiking by myself, whereas at Gold Coast it was basically like Miami. Like I would be on the beach just chilling. It was really, really nice. So yeah, in that sense, Australia is kind of like Canada in that it's very different from one side to another. Anything about Australia surprised me? I think the initial thing that really surprised me was everyone's accent. I know that's not a very sophisticated answer, but I think just like customizing myself to the accent, as well as they have a lot of little like sayings and slang words that I wasn't used to. So often they would add IES to the end of words. So for example, they'd call biscuits thickies, or sometimes I'd have to say, pardon me, can you repeat that please? Because I couldn't understand. In terms of experience different from the first cohort, I think what was a little bit different was that a lot of the Kiwi scholars in the first cohort were based in Sydney, Australia, and I was in Melbourne. And so I think Melbourne was a really, really neat place to be because it's like a very cultural city, like filled with many little laneways, street art, lots of buskers and artists, and I had the opportunity to go to Sydney as well, but I felt Sydney was beautiful, like beautiful harbor and stuff, but I felt it was a lot more businessy, and it had a different kind of vibe than Melbourne did, so yeah.
Great, thank you. Any other questions? And again, if you're online, please type them in the chat box. Anybody in the room have a question, feel free to put your hand up. while we're waiting, sorry, Jean, I was looking at Christy's question. Jean, I asked you to keep an eye out for something before you went to Australia, and so now I'm going to ask the question, did you see one?
So James asked me to take a picture of a Tasmanian devil for him, and in fact, I did see one. The first one I saw was a statue of one in the airport, but I actually did see one when I was in Tasmania, a real one. I was driving late at night. It was very, very dark out, and one of them actually stopped in front of my car. So don't worry, it was okay, and I was okay. But yeah, it was kind of like deer in headlights on the road for a bit. So that was the only time I got to see one. But yeah, it looks like a little bit of a large black rodent. Quite an interesting animal.
Okay, so I'll assume I didn't get a picture of one because of the circumstances.
Yes, I would have for sure, but it was quite scary in the moment.
That's completely understandable. Anybody else have any questions, either online or in the room? I'll pause. So I will assume silence means everybody feels comfortable with where you're leaving it here, Jean. So I want to thank you very much for taking the time to log in remotely and complete your webinar. It was very informative. I'm sure everybody enjoyed it. We currently actually have a student in Melbourne as part of our QES scholarship program. So picking up where Jean left off with the Prevention Tracker Group. So Jean has paved the way for other scholars, and we appreciate the work that you've done. Just to draw your attention to the screen right now really quickly, a couple of links that I'd like you to pay attention to. If you're interested in applying to our Queen Elizabeth Scholarship Program here at McMaster, that first link has all the information you need. If you want to know all about our webinars and presentations that we have throughout this term, and we will be doing this every week, for the most part Wednesdays at 4 with the odd exception, please go to that second link and get the full list of webinars and the links to them. And lastly, all of our Queen Elizabeth Scholars write a blog to talk about their experiences, what they went through from different perspectives. So please visit the blog page and read what our scholars have to say about their experiences. They're quite enlightening and informative. And thank you, everybody, for joining us. Thank you again, Jean, for doing your presentation. And we look forward to seeing everybody again really soon. Thanks a lot.